and um, I manage the clinical care aspect of the program, as well as the research. I do the research coordination for the studies that we're involved in. Yeah, that's
great. Thank you. Sorry, I didn't mean to interrupt you with the recording there, but the computer just warned us all that the session is being recorded. So sorry about that, Andrea, but thank you.
No problem.
All right, I'm going to go clockwise on my screen. So Mitesh, that makes you next.
Sure. Thank you, Jamie. My name is Dr. Mitesh Thakrar. I'm one of the pulmonary hypertension physicians in Calgary. So I've got a particular interest, obviously, in pulmonary hypertension. I'm also the Deputy Medical Director of the Southern Alberta Transplant Program as well. So I also do lung transplantation and am the Educational Subcommittee Lead for PHA Canada. Yeah, and thank you for having me here.
Great, thank you. And Kelly.
Yeah, so I'm Kelly Gould out of Moncton, New Brunswick. I work with Dr. Christina Kemp in the Pulmonary Hypertension Clinic. I'm also a cardiac nurse and a heart failure nurse as well.
Welcome. And Dr. Langleben.
Hi, I'm David Langleben. I'm a cardiologist. I direct the Pulmonary Hypertension Clinic at the Jewish General Hospital, Montreal, with my colleagues Andrew Hirsch, Ali Abu Al-Saad, my wonderful coordinators, Lito Zenko, Jessica Pinto, and a very large staff that I can't mention right now.
Great, welcome. Okay, well, we've got questions starting to come in already. So while those just take a second to get started, I'm going to ask a question that came into us from somebody who couldn't make it this week, and so emailed their question ahead of time. And so I'm going to read it directly so I can make sure that I don't miss anything. Make sure. There we go. Okay, so this patient asks, can a lot of weight loss make pH go away in some people? I don't mean will it decrease symptoms. I'm talking go away. A cardiologist said that once, but the credibility of a pH specialist would be appreciated. So, can dramatic weight loss make pH go away? We'd like to tackle this one first. Yeah, please go ahead.
So it's a good question. Weight can act negatively in terms of pH in a variety of ways. It can be associated with sleep apnea, which represents a stress on the lung circulation. It can be very commonly associated with stiffening of the heart, what we call diastolic dysfunction. And now, again, we're saying pH, not PAH, although of course weight can worsen PAH by adding factors to it. But many people we see present with pulmonary hypertension and turn out to have principally what we call group 2 left heart disease dysfunction, diastolic dysfunction. Some have group 3 with sleep apnea. So weight does play a role. Never mind the fact that it places an increased workload in terms of exertion and can worsen someone's symptoms. So the short answer is yes. Now, can it disappear? If it's principally group 2 and there's no other cause, yes. Now disappear. I mean, it'll diminish. It'll diminish significantly and put the person into a low risk group. It may not go to 0, obviously. We have seen cases of sleep apnea associated with severe obesity, where the person, in one way or another, lost dramatic amounts of weight. The sleep apnea improved. Of course, they wore CPAP and other things. And yes, the pH melted away to a great degree. Weight loss won't make group 1 PAH disappear. So it'll still help it though, because again, if you're carrying around a 50-pound bag of potatoes on your shoulders, you're going to be short of breath. I know I will be generally. Okay, but if you can get down to a more ideal body weight, it's just easier on the cardiovascular and respiratory system.
All right, thank you. Anything to add? Any of our other panelists? No? Okay.
That was great. Thank you.
Good. Well, we have perhaps somewhat of a related question for some people, because I know I talked to lots of folks in the community who struggle with having gained weight since their diagnosis or since their symptoms began, and they very often want to exercise, but they have trouble exercising, obviously. So the question here is, starting an exercise program, how is it best to get going? It's probably a discussion you have now and then.
Fascinating question, and we've done a little bit of work on this very question in Calgary. So a number of years ago, we started looking at a program using a form of yoga called Iyengar yoga, which had dramatically positive results in terms of quality of life, in terms of energy levels, and patients reported perceived benefits from this. And many of my patients who were part of that study are still doing that to this day, almost a decade later. And so certainly that was one form of exercise that got a lot of attention and was very positive. One of my colleagues currently is looking at an app-based program to try and help with exercise as well. And there's certainly a lot of these app-based exercise programs looking in all sorts of different types of cardiopulmonary health, in transplant, in asthma, and he's certainly looking at one in pulmonary hypertension. So there are these sort of quote unquote experimental models that have come out over the last number of years that have suggested that. But I think ultimately probably the best advice that I've heard from other colleagues when I was training elsewhere was, any form of exercise is good exercise. You just have to listen to your body, right? And so as opposed to, trying to get to maximal heart rates like we would if we were training for the Olympics or training to be a competitive athlete, we don't want patients, pushing through their limits. We don't want them, quote unquote, feeling the burn or any of those other euphemisms we use in exercise, right? So getting moving is good, but if you get to the point where your body's screaming at you, you have to listen to it. That'd be my advice.
Thanks. Kelly, to add.
Yeah, so as a former cardiac rehab nurse, I always encourage people to look into cardiac rehab and pulmonary rehab programs in their area. It's a great resource. What I learned is that absolutely listen to your body. Your body will tell you when you've done too much. And to pace yourself, I think over the last year, just because of what's been going on, a lot of people have also become deconditioned because people haven't been out and being active. And just what we counsel all our patients on is just a gradual return to activity. Get out and walk. If you live in an apartment building and you can get out in the hallway, walk in the hallway, do 10 minutes, see how you feel. And then just gradually work up from there. And for a lot of our PH patients too, we want to maintain what they have. We don't want them to lose anything. So maybe you're not going to train for an Ironman or a marathon, but we want you to maintain what you have.
So related to this, somebody's asking a follow-up question of how low can your O2 stats, your SATs, your saturation, safely go when you're exercising? Anybody want to answer that? Is there a reasonable answer to that question? Maybe there's not a simple answer to that question.
It is a bit complex because it also depends on, again, as Dr. Langlebit had said earlier, it depends on the cause of your pulmonary hypertension. There are certain diseases, for instance, interstitial lung disease associated pulmonary hypertension, where unfortunately no amount of oxygen is going to, supplemental oxygen is going to prevent you from desaturating. Whereas, in PAH, we see a little less of that, although it's not, again, universal. But my general guidelines for most of our patients is, we would love to see saturation stay above 88 or 90%, partly because once you start to go lower than that, you very quickly lose oxygen carrying capacity on hemoglobin. The shape of that dissociation curve is such that the amount of oxygen delivered to your tissues once you start going below about 88% rapidly falls off. And so the moment that happens, your heart has to work harder to deliver the same number of oxygen molecules to the tissues. And so if you've got a pump that is already struggling, to make it struggle more is counterintuitive. And so that's why generally we would want SATs above 88 to 90%. But there are some diseases that are associated with pH that make that very, very difficult.
Yeah, Andrea.
That's great advice. Just to further comment on the idea of exercise, something I find that I'm often explaining to my patients is to reframe the way we talk about exercise too. The word exercise has a certain connotation to it, especially if you were extremely active or lifting weights or doing, certain things before a diagnosis, or comparing yourself to other patients, other people in your life that are exercising. For some patients, good exercise, a good workout for their heart is doing some housework or going to the grocery store. And so really emphasizing to stay active, do what you can yourself, conserve your energy, save your energy, and for times that you do want to, do some muscle training or something, but reframing that so that you're being kind to your body and working with your body, listening to your body, having a positive relationship there when your body is telling you that you're short of breath or that you need to slow down, working within those constraints to really see some progress, and to further what the good advice that's already been shared. Just the something that I talk to my patients a lot is, everyone gets short of breath when they exercise. So a little shortness of breath is okay. It just means you're having a good, your heart and lungs are having a good workout. You're just going to get there faster depending on the severity of your symptoms and your disease. So whereas your sibling or your friend might need to run, you going for a short walk is going to exert the same amount of exercise, and that's all positive. So.
Good. Okay. So thank you for that. I think the discussion of exercises is really, really important, and one we need to kind of keep having. And in fact, in the next issue of Connections, there's going to be an article with an interview from Dr. Mack that shares some more information for folks around pH and exercise. So you can look for that coming up soon as well. All right, we've got actually a really great question. I think is one that we can, kind of gets us back to basics here a little bit. But maybe somebody could just take a minute to differentiate for us what we mean, or what the difference is between pH and PAH. So I know I can answer this question, but I don't think they want to hear from me. So yeah, please, Dr. Langleben, take us back to basic.
So high blood pressure in the body, high blood pressure in the lungs is quite simply called hypertension, which translates into high blood pressure, or high pressure at least. There are many, many different causes of high pressure in the lung circulation. All of those fall under the envelope of pH. And then there's subtypes that we've talked about a bit already. We've realized that some diseases cluster together in terms of causes, mechanisms, potentially cellular changes within the circulation. PAH is a somewhat special group where, first of all, there don't appear to be, by definition, excludes some of the very common causes, including left heart disease and lung disease and blood clots, chronic thromboembolic disease. And you exclude those. And what you're left with is a group of diseases that have surprisingly varied causes. From connective tissue disease to HIV to a hole in the heart to liver disease to having genetic abnormalities. And when you put all those together, they actually, if you look at the lungs, have tremendous similarities in terms of the changes and abnormalities within the lung circulation, where most or at least very much of the blockage is happening in very small blood vessels just before the blood capillaries. It's pre-capillary mainly. So PAH is this very unique group of diseases. And when you look at the medications that we've tested, and that seem to be effective in various types of pulmonary hypertension. There's a cluster of medications that you're well aware of that work on PAH, but often don't work on the other ones. The reason is that the underlying mechanisms are probably different. So PAH is a subtype of PH. Everyone with PAH has PH, but not everyone with PH has PAH. I'll stop there.
Okay. I'll just add that the PHA Canada has resources on this. So if you're interested in more, sort of reading something or watching a video that helps you understand this better, or sharing it with people that you know to help them understand it, you can go to our website, and I put a link in the chat to a page that specifically has some videos, some really short videos, both in English and in French, including one specifically on this topic of what the different types of pH are. Okay, we've got another question. Actually, I'm gonna go back to the topic of exercise again, because we have one more question here. And so before we move on, we'll circle back again. It relates to this. I think this question of desaturation. So the question is, what if with treatment you have normal pressures, and with treatment you don't desat when you are walking? Why is it still so hard to go fast or go up a hill? So you've got somebody who's they're treated, they generally feel okay, they're not desaturating when they're out moving around, but they still can't do what they maybe want to be able to do. So what's going on there?
So I can pretend to be a cardiologist, even though Dr. Langlebin's here as a cardiologist, but I can try this one. So I think there's a couple of mechanisms as it pertains to what we call cardiopulmonary exercise physiology. And so the first of which is, especially in the prototype of PAH or CTEPH, the heart is only able to generate a certain amount of blood flow per beat, and we call that stroke volume. And really, our ability to generate blood flow is a multiplication of our stroke volume times our heart rate. And because of the obstructions, the tiny microvascular obstructions in PAH, or the bigger obstructions we have in CTEPH, the heart's ability to generate that stroke volume is limited, and it's fixed. And so the only mechanism we have in that scenario to generate more flow that we need for exercise, more blood flow that we need for exercise, is to increase our heart rate. Whereas opposed to if you don't have PH, you can increase both heart rate and stroke volume together. Very, very quickly, though, we hit the limits of how fast our heart can go. And once you've done that, you start to flip into a form of metabolism, which you might have heard of, called anaerobic metabolism. And anaerobic metabolism cannot be sustained for very long. You start to produce acids that the body has to get rid of, and that causes the burning in your legs. It causes you to breathe faster, and eventually you just tire out. And so primarily the reason why we struggle and feel short of breath is because of the generation of that lactic acid. And so we hit that lactic acid threshold sooner in pulmonary hypertension because we cannot increase our stroke volume. And that's kind of, I think, as simplistic as I can think of it.
How did he do?
I'm ready to be a cardiologist now.
Great, excellent, thank you. Anything to add, Kelly or Andrea or David?
Well, it's interesting. The lung circulation. Sorry, Kelly, does someone want to talk?
I just think people have to be forgiving of themselves. I don't have pulmonary hypertension, but I never could do stairs. No matter what I ever did, a lot of people have to train for that, and it's just not in some people's capacity. And even if you were able to do it before, just to forgive yourself and to pace yourself, and that, it's just changed and it's okay.
Yeah. Great, thanks. And go ahead, Dr. Langleben.
So lung physiology is actually pretty unique in the body, because the lung circulation is designed to take very significant increases in blood flow when we're exercising. Like, let's say our resting blood flow is about 5 liters a minute, and person starts jogging or running or whatever they're doing, and their flow goes up to 10 liters, 15 liters, sometimes easily, and never mind Olympic athletes. What's remarkable with the lung circulation is that extra flow doesn't result in any significant increase in pulmonary artery pressure in a normal lung. And you ask how that can happen. And the analogy I always use is you have to imagine a tree in spring where, you know, some of the leaves have opened, but not all of them have opened. They're sitting there waiting, okay? And as we're sitting here, those of us that have normal lungs, we're probably using about a third of our leaves. And what happens when a person jogs or runs is that suddenly, instantly, many more of those leaves open and accommodate the flow. So if I'm running for the bus, for instance, you know, my leaves open up, then I get on the bus and sit down and maybe huff and puff for a minute or two, okay? And those leaves close up again to wait until the next time I need them. Now, what happens in PAH, unfortunately, is that a lot of the very small branches just before the leaves get diseased. And in many people, 60, 70, sometimes 75% of the branches can no longer take the flow, which means that the lungs are relying on the remaining 25% of the leaves, and they're being used all the time. And so when you try to push more flow through, and that's, you know, you talked about flow limitation before. When you try to push the flow through, first of all, you need it needs more pressure to drive it through because those are fully used already. The leaves are fully used. And the heart can't do it except by increasing the heart rate. And it doesn't do it very successfully either, okay? One of the puzzles about our therapies is, you know, how do they help? And we don't know if they're restoring more leaves. The other day in one of the sessions here, I mentioned that I'd seen some exercise data on one of the recent agents, would suggest that some of the people at least could again push more flow through without a higher pressure. And that's a very encouraging thing. And to me, that's the gold standard. The gold standard of any effective, truly effective therapy that we're going to give in PH, like a nearly curative therapy, should allow the person to open up a whole bunch more leaves. And that should be our goal, really.
Thank you. We're getting more questions related to this topic. It's clearly on people's minds this week. So when walking, how high is too high of a max heart rate then? And the question just says, does it matter if you are still vertical and walking? Or is there a max as a safety to track for the heart? I also have a heart VSD and lung pH, this person says in the chat. So I guess the question really comes down to sort of similar to that oxygen question of, like, you know, how safe is it for your low oxygen to get low? How safe is it for your heart rate to get high?
Not to take this away from the cardiologist, but because I get asked this as well, the answer I give is sometimes, so certainly there are heart rates that are unsafe, too high, so I won't speak to that. But in general, we are also concerned, sometimes more concerned with how you're feeling. So is your heart rate high and you're having chest pain, chest tightness, feeling a lot of heart palpitations where your heart is maybe beating irregular or uncomfortable? I think in general, it's recommended that you would stop exercising or slow down before you get to that point, or when your body starts giving you those warning signs. So sometimes the monitors can certainly be helpful too, but listening to your symptoms is also important. And then, as the question sort of alludes to, there are, and as we've discussed, many different diseases and situations that go along with pulmonary hypertension. So it's usually not just the only problem someone has. And if you have other, you know, if you've been diagnosed with irregular heart rhythms, congenital heart diseases, different considerations like that, then that would be important to talk to your doctor, probably, to get specifics for your case and what's concerning for them.
Yeah, and just remember everybody's different and everybody's heart rate is different depending on how you're made up. And everybody these days has like one of these going on. So people get a little obsessed about their heart rate. But even in elite athletes too, we don't get so hung up on heart rate as much as we used to anymore, but more about how you feel.
Okay, great. Okay, we're going to move on to a couple of other questions. We've got a question here that says, how long will my workup testing for transplant be good for? After testing was done, I stabilized and I did not need to be listed. Will I need to redo it if I get sick like that again? So there's actually a session happening right now on preparing for transplant. So I think there's probably a whole different conversation going on over there. But thanks, Marianne, for this question. We see this question happen online quite a bit, where people, ask about this process of getting worked up rather than getting listed, but just getting worked up for transplant. And so here we've got somebody who's been through that process, but like, how long does that workup last before you have to redo it?
So some of it's dependent on which center you're being transplanted at. So every program will have subtle differences in what they want to keep updated and how frequently they want to keep it updated. So I can only speak to the Alberta process, but I suspect it's probably not dissimilar across the country. So certain tests need to be repeated very frequently. For instance, we might do blood tests once a year, or maybe more often, depending on the circumstances of patients, to make sure that the rest of the body continues to hold up to the possible risks of transplant. We look for things like antibodies to your donors, and so those tests need to be repeated frequently. And other tests, such as cardiac catheterizations and bone density tests and those kinds of tests would be perhaps once a year or even less. And so, I think in general, once patients have been worked up, the transplant programs that they're with will continue to sort of do the data sets and the data collections as they need. But I think some of the more invasive tests we try to do less often. In the setting of the pulmonary hypertension audience, it's usually not the transplant that will guide when you need your next heart cath, but it's probably more likely the disease itself that will guide that. And then in terms of the other stuff, like I said, somewhere in the neighborhood of about once a year for most of the non-invasive stuff is pretty typical for what we organize for our transplant patients.
Any differences in Quebec? No. Okay, well, I hope that answers your question, Marion. You can let us know if you've got any follow-ups, please. Okay, another question here, surgery related. Can you have surgery when you have PH? They just mean like, let's say surgery on a thyroid, for instance. Can the PH patients be put to sleep? I sometimes hear they can't be. So why can some people maybe and some people not?
I think they should be put to sleep in experienced centers, first of all.
Mm.
It's not a question of putting to sleep. You can be put to sleep anywhere, including, my sofa, if I'm watching a game, but it's more a question of getting the person to wake up healthy, and see them through the operation. And that takes very skilled anesthesia that's used to dealing with seriously ill patients, cardiac patients, patients with respiratory disorders, etc. That's not to say that surgery is without risk, and some surgeries certainly carry more risk than others. So, thoracic surgeries, cardiac surgeries, abdominal surgeries, gynecologic surgeries, anything where you're sort of inside, deep inside, carries more risk than other surgeries. Nonetheless, in the great majority of cases, patients can be taken through those surgeries quite successfully. There's the issue of doing things laparoscopically versus open. Each of those techniques has its pros and cons. For instance, to do laparoscopic surgery in the abdomen, you have to pump in a whole bunch of air, which can sometimes prevent the blood from returning up to the heart. which can be more problematic. There's the issue of spinal anesthesia versus general anesthesia. People seem to, at least the populations seem to be afraid of general anesthesia, when in fact, sometimes it's much gentler, in fact, in terms of stability and smoothness of the anesthesia than a spinal, depending on the surgery again. So again, in an expert center, it gives the patients the best chances. There is a small risk. Certainly, someone with PH or significant PH undergoing surgery compared to someone that's never had PH is at a higher risk, but it's not a prohibitive risk.
I would also add that it's a good idea to talk with your PH specialist, cardiologist, respirologist before even some dental procedures can be pretty major, especially if they're administering something like nitric oxide, different medications, depending on the combination of pulmonary hypertension medications that you're on. There can be some important considerations for that procedure. And I know Dr. Hambley likes to, it's not a matter of recommending yay or nay to a surgery, but rather just providing information, conversation, making sure the surgeon or physician is aware of any potential risk or complications to look out for, just so that it can be done safely.
I agree, and I think it's very important to develop a strategy for each patient to ensure that their PAH medications continue to be administered, or if for some reason they can't, to switch to alternate PAH medications while they're peri-op and not in a situation where they can go back to their regular medication regime.
Right, because of course, folks who are on, say, IV infusions or something are not going to suddenly want their medication stopped. Obviously, yeah. Okay, well, thank you. That's very helpful. That's interesting. Okay, we've got a question here on COVID vaccination, everybody's favorite topic. Is there any data on whether COVID vaccines aren't as effective with people who are immunocompromised or have negative long-term effects, or are these just myths? Mythbusters! Who wants to go first?
I think the current recommendations of the PH associations, of the PH physicians, of the connective tissue disease, the rheumatologists, physicians, where many of the people are somewhat immunosuppressed potentially, is that everyone, if possible, should absolutely have the COVID vaccine. We must remember, certainly, look, I mean, mainly we're getting those RNA vaccines now, the RNA-based vaccines. They don't take over the body. They're in no way infectious. Now, does one get an attenuated immune response? I'm not an immunologist, but to my understanding, they still provide significant protection. And so on the balance, absolutely, anyone that's listening to this now should be getting a vaccine.
Dr. Thakkar, did you want to add anything?
Yeah, I was just going to say we certainly have looked at this question in our transplant populations, and the data does, as Dr. Langleben said, there seems to be an attenuated immune response to the vaccine, but we don't have great measures of what that means clinically to patients. We're measuring simply an antibody in a test tube, and we don't really know for sure that there isn't still good protection clinically. And I think that's what's really, really important, is that there's probably a bigger clinical benefit than what we see from an antibody response, because the immune system is not simply an antibody, it's much more than that. The second sort of caveat to that is we know that these vaccines have been administered to thousands and thousands, if not millions by now, of individuals that are immunosuppressed and on medications that immunosuppress them, with no signal whatsoever to suggest that they're unsafe. So these are incredibly safe interventions that have some degree of clinical benefit, probably a significant benefit. And then the last thing we know is that if immunosuppressed individuals contract COVID, their mortality is exceedingly high. So for instance, in the lung transplant literature, 1 out of 3 lung transplant recipients who contracts COVID doesn't survive their COVID infection. And so, the risks of catching COVID are far, far, far higher than the risks from the vaccine. And so any clinical benefit is important. And so, I used to say the only contraindication to not getting a COVID shot was not having any arms, but truthfully, you can get your shot anywhere. And so there really, unless you have a bona fide allergy to the components of the vaccine, which are incredibly uncommon to have those allergies, there really is no reason to not get a COVID vaccine.
So related to this question, we had a question the other day about whether or not this potential population, lung transplant recipients in particular, should consider a third booster because of this attenuated immune response.
Yeah, it's a great question. And the clinical trials are ongoing at the moment to look at that very question in transplant recipients. So we should hopefully start to have that data later on this year, or early into next year. But at the moment, there isn't a possibility to do that in any province that I'm aware of at the moment. But I think we're specifically asking that question.
And certainly we know the information about vaccines changes pretty rapidly. In fact, on Saturday, when we were having a conversation about PH and COVID at the opening plenary, Dr. Granton was very clear in saying to everybody that in response to the question of whether or not folks who had AstraZeneca vaccine, whether or not they could or should consider a different vaccine for their second shot. And, his response was just like, get whatever second shot you can get first, like same with the first shot, whichever one you can get first, you should go and get it. And then this morning we heard the National Advisory Council on Immunization change their recommendation. And their recommendation is now that if you've had a first shot using AstraZeneca, that their recommendation is you should consider a different shot for your second dose. So in light of that new recommendation from NACI, does anybody have anything new to say, or would you still say that Dr. Granton's advice is sound?
It's going to be driven by whatever the governments give you. Honestly, our patients may go in and ask for vaccine X, but if the government decides it's going to be vaccine Y, it's going to be vaccine Y, and that's driven by whatever decisions and availability of the vaccine.
Yeah. Okay. I know it's been very hard for some people to sort of have confidence in these decisions because the information does change rapidly. But I think like you were just saying, Dr. Thakar, it's because the science is happening fast. There's a lot of research happening really, really quickly. And so the evidence is changing and the recommendations have changed as a result of that. But at the end of the day, the evidence is also very strongly telling us that there's no reason why folks shouldn't be getting vaccinated. And so we have been encouraging people to vaccinate, and we will continue to encourage folks to get vaccinated, and we'll continue to encourage you to get vaccinated for the flu too, and for other things as well. Okay, great, thank you for that. So, we've got another question going back to some of this terminology we've been using. What's the difference when someone says they have IPAH, which stands for idiopathic PAH, versus just PAH? So what's that I there for? What does that mean?
So I talked before about PAH, and I said there were a lot of different causes: connective tissue disease, HIV, holes in the heart, liver disease, a whole bunch of stuff, drugs and toxins. Really, the first description of PAH, there's a pathologic description from 1893. But the first description of the current description of PAH was, or what's IPAH, was in the 1950s. From the first author was someone named Drysdale. Why was it then? It was then because it was only after World War II that people started doing cardiac caths with any safety and understanding of what they were doing. And by the way, the people that developed right heart cath won a Nobel Prize. I don't know if people in the audience realize that. It was a major advance, major advance. So there was a disease identified where people had pulmonary hypertension without any obvious cause. And it was clearly pre-capillary. And in those days, they called it primary pulmonary hypertension, which was the terminology for pulmonary hypertension. We don't know why. that's basically what primary pulmonary hypertension is. And later on in the terminology, that was just changed to a more modern term, which means idiopathic. It's actually an old term, but idiopathic means of unknown cause. Now that's evolved, okay? Because we know that people can have genetic mutations that cause identical, what we would have called IPAH. So if you took a population in 1960 when we weren't doing genetics and you took 100 people with IPAH, a significant number of them might have had genetic mutations and we just didn't know about it. With the advent of modern molecular biology and genetics, we know that there are identifiable people carrying genetic mutations. So in a way, heritable PAH is identical to IPAH in terms of the disease process. It's just it's no longer idiopathic because we have an explanation for why the person has PAH. Sorry, and by the way, Dresdale's original publication included a family. Okay, so we knew immediately that there were familial cases and inherited cases. And so IPH just means we've looked for all the other causes, it's not there. Then there's a chance within that group that we will have an identifiable genetic mutation. And as we look more and more at the genome in these people, we're picking up more mutations, and they're fascinating. And hopefully they'll lead one day to what's called personalized medicine, much as is done in cancer now, where you know subject A has a certain mutation that will respond to medication A, and subject B has a different mutation that might respond to medication B.
That that genetic relationship, is that gene always inherited?
So again, there has to be a founder effect. I mean, someone has to have had the first mutation. So the question is, how far back can you go in terms of analyzing people? Who's alive to study? Now, we track our patients and screen them for mutations. And then if we find them, we go backwards. We also go downwards, forward, and laterally to sisters and brothers and nephews and nieces, and it suddenly becomes a very complex family tree. So that depends on a few things. It depends on, first of all, being able to establish what we call a genealogy. In other words, a family tree, a proper family tree, and try and understand it. Okay, it has to go back to the willingness of people to be tested genetically, because carrying the mutation doesn't always mean that a person's going to have PAH. We know that's, in fact, the most common PAH gene has what we call variable penetrance, meaning that it can skip generations even though it's being transmitted through. Okay, and some people will never get PAH with it, or and yet their kids might, or their grandchildren might. So people have to want to be tested. The third thing is do you want to test something that right now doesn't have a curative treatment? So there are many issues for parents, for children, in terms of, and it takes very careful genetic counseling for people to make an informed decision as to what to do about it. And we do all this, of course. Nonetheless, there are some mutations that carry a particularly bad prognosis that the person might want to know sooner, because those people almost guaranteed will not respond to PAH medications and should be referred more rapidly for transplant. There's one particular mutation that causes pulmonary veno-occlusive disease, for instance, where we know that. Okay, but as we understand more about how the mutations work and we have personalized therapy, I think there will be an increased push to try and understand who should be identified, how do we identify them, how do we screen them. Someone that's carrying a mutation, that's a known carrier, the current recommendation, and is asymptomatic, there's no disease, the current recommendation is at least that they get an echo every year.
Right, as a screening mechanism. Great.
Absolutely, yeah.
Thank you. That was really interesting. Okay, so thinking still about this population of idiopathic PH patients, Is there much study or data on those that are specifically vasoresponsive? Maybe we could talk a little bit about what that means. Or would it be worthwhile to have more studies on this population? So what do we mean by idiopathic PH patients who are vasoreceptive or responsive rather?
I don't want to hog the discussion, but let me just talk about this, okay? Because it's an area, particular area of interest for me. The same way I said that, you know, amidst this 100 people that looked like idiopathic PAH, there were many people that carried a mutation. Very rarely, maybe 5%, maybe less, well, around 5%, let's say. There's another group, you could have sort of two patients side by side. Usually they're young women, side by side, looking identical. And one of them will have what we call classic PAH, which is the idiopathic PAH, which is the usual type, and we treat it with our usual medications. But another group will look identical until we test to see whether their blood vessels can relax. And they have a problem of blood vessel tone instead of the blood vessels being plugged up with cells. Everybody else with idiopathic, the blood vessels are being plugged up with cells. These people look identical and have high pulmonary pressures. If you give them a vasodilator, and the way we do this is on the initial cath in the cath lab, once we suspect they're idiopathic, we give them inhaled nitric oxide, but there are other agents you can use. And there are certain criteria that will define a bed that relaxes suddenly and opens up many more leaves, in fact, on the tree. Okay. And those are vasoresponsive and they're very rare. Why are they important to find? Because most of the true vasoresponders will respond to high-dose calcium channel blockers, high-dose calcium blockers, which of course are an entirely different therapy than everything else we use, and seem to go on basically the rest of their lives quite healthy with those high-dose calcium blockers and are in a way cured. So here's another example of personalized medicine. You've identified a subgroup that responds to a very personalized therapy. Interestingly, it's a therapy we use all the time for, you know, blood pressure and other things. And the pills are dirt cheap, and yet you've cured them, you know? And so they're very important to find. They're very important to find. You don't want to miss them. You don't want to, and when you find them, you treat them. Now, what's interesting is we've studied this, and we've studied the number of leaves that they have. And unlike all the other patients with idiopathic PAH, which won't respond or open leaves when you give them nitric oxide, these patients, and they're very rare, you can show that they're just opening the whole tree up when you give them the nitric oxide.
So the answer to the question, would it be worthwhile to have more studies? It sounds like it would be.
There's a group at Vanderbilt University that's doing a huge amount of research on these patients in terms of genetics. And I hope they'll come up with an answer. They've already identified something that involves several different genes in terms of sort of screening for these people. It's not perfect, but it's on the right path. And I think within a few years, they'll have sorted it out. We still don't know what the real defect is in the blood vessel. It's something in the smooth muscle probably that causes the vessels to constrict.
Do you think that genetic testing is going to become a normal part of just a PAH workup at some point in time?
I think we're getting pretty close to that for a lot of patients. I think, you know, as Dr. Langlandman said, is, you know, as you go down that tree of diagnosis, you know, the first is exclude group 2, group 3, group 4. Now you're into the group 1s, which is PAH. You go through and make sure you don't have connective tissue disease, liver disease, et cetera, et cetera. And I think you get down to this diagnosis of IPAH. And as Dr. Langlandman has said, I think we're now saying, well, IPAH probably for half of them is not as idiopathic as we thought. And I think that's where the genetic testing fits in is, you know, before we classify somebody as truly idiopathic is, you know, we probably need the genetics to truly get to that point. And the moment that it starts to inform our treatment decisions and our ability to prognosticate how well somebody's going to do, the moment we get to that, it's basically the time for it to be routine practice as well, right? But I think we're still in this sorting it out, categorizing the different mutations and understanding how those different mutations behave with treatment, conventional treatment that we have right now. But yeah, I think we're already there.
Great, thank you. Okay, we're going to need geneticists on our panels in the future. Okay, we've got a few final questions. I've kept a couple that are a little bit related till the end. So I'll just go to this new question here. It says, could someone with portal PAH, so related to liver disease, have a double transplant? I'm not quite sure if they mean, can someone with liver, with portal PAH, liver disease, have a double lung transplant, or if they mean, could they have a double transplant in that lung and liver simultaneously? Has that ever been done in Canada? Anybody know? What about the first part? Can those folks have transplant?
So it's a really important question. Yeah, it's a really good question, because unfortunately, portal pulmonary hypertension is typically an exclusion for undergoing liver transplant. So people who get portal pulmonary hypertension by definition have cirrhosis of their liver, and many of these patients are being considered for liver transplant when this is discovered. And so, but unfortunately, it often puts a bit of a roadblock in that case. There are reports from around the world of patients undergoing combined lung and liver transplant. I must say, I haven't seen much in the way of doing it for portal pulmonary hypertension. Dr. Langleben can correct me if I'm wrong, but the typical reports that I have read about these sequential transplants, or these simultaneous transplants, is in the setting of somebody with cystic fibrosis who has damaged lungs from cystic fibrosis and then cirrhosis from cystic fibrosis. Mm. The big risk that portal pulmonary hypertension poses is that there's a huge, when you do a liver transplant, there's a huge shift in blood flow back towards the heart the moment you take the liver out. And that stress on the heart is the problem, because if you already have pulmonary hypertension and then you get a big return of blood to the heart, that can cause patients to decompensate very, very quickly. And the risk of doing the lung transplant first is any major surgery puts a big stress on the liver. And so I haven't seen many, if any, reports about portal pulmonary hypertension undergoing simultaneous transplant. But I don't know, Dr. Langleben, if you've seen any.
Oh, I haven't, but I agree with everything you've said. Thanks.
Okay. All right. So we've got two final questions here. They're related, but they're different. So the first question is in response to, I think sometimes we hear folks on panels like this say that, or give the advice to folks who are newly diagnosed, don't go on the internet. Like, don't read what's on the internet. That it's scary and it's it's stressful, and so they're warned against going onto the internet. And yet, of course, saying that to people is like almost an invitation to a toddler to like not eat cookies, right? It's like you immediately want to go and read what's on the internet. So the question here is like, where can people go to get credible information? Even if it's not them, like their friends and family are going to keep looking. So where should people go for credible information? And then the related question is a little bit more specific, and that's what's the best website, or where can someone go as a healthcare provider to learn more about this so that they can better support their patients who have PH? So just generally, any good particular credible websites you want to recommend, and then secondarily, specifically for healthcare providers who want to better support PH patients. Kelly, you want to go first?
Sure. Well, your site is a fantastic site. And I recommend all my patients go there. And even healthcare providers go there. It's a fantastic site. It's got great information, fantastic resources. The US also has a fantastic site as well, and so does the UK. So that's where I usually direct my patients to go, and any family members or even staff members that I work with who are interested in knowing more, that's where I direct them.
So whether family, friends, or healthcare provider, the patient association's got you covered.
Absolutely. 2 thumbs up.
Nice.
And PHA France for French stuff.
Mm-hmm.
Yep.
Yeah.
And then the Mayo Clinic's got some good stuff as well.
Nice. Andrea, any that we haven't mentioned yet that you like as well?
Yeah, no, I absolutely agree. PHA Canada is where I send my patients as a rule. We also sort of walk through, even in clinic, what it means. We say, if you're going to Google pulmonary hypertension, here's what you will find. You will find, that it says a life expectancy of 2 years. This is what you will find, and this is not true for you. And I think it's important, we constantly ask our patients to come back to us with specific questions. We promise to be honest and forthcoming when they want questions about their disease and their prognosis and their response to treatment, because everyone is individual, everyone responds differently. And like we've talked about, there's many different ways pulmonary hypertension looks. And so we, like Dr. Legleben said earlier, we try to really give an individualized treatment advice. And so the information on the internet by nature is general, even if you're in support groups and connected with other patients, those can be very helpful. I know patients can find that relationship with other patients to be very beneficial. But even that, everything that is true for your friend or other person is not necessarily true for you. And so just keeping that in mind, that not everything on the internet applies to your situation. And yeah, going back to your physician for specifics on your situation as far as information, I think is important.
And by the way, I think coming from very multi-ethnic Canada, there's a Greek PH association in Greece. There's a Spanish PH association, and they have a lot of literature in the original languages, and it helps. It helps. There are Arabic PH associations. There's one in Israel. They're all over, and they have high grade information. Which we can refer our patients to.
Yeah, all of the international PH associations are work together, and the larger associations like the US and like PHA Europe do a great job of helping to build the capacity of smaller organizations and to help share resources so that we can do exactly that. So we can make sure that the resources are then adapted to local populations and available to as many different people as possible. Okay, thank you for those questions. I'll do my best to put some more websites into the chat box, or if anybody else has some to add. We do have another last question, so I'm going to add it in here before we finish. Someone says, Leah says, I have been diagnosed with IPAH, idiopathic, for the past 6 years, but looking back had Raynaud's syndrome, poor circulation, blue lips, burning lungs, and red face running or playing sports, even as a child. Is my IPAH something that just develops suddenly, or is it possible I've had it all my life? And I hear this from patients a lot, that they say, oh, I was diagnosed 5 years ago, 4 years ago, 7 years ago, 8 years ago, whatever. But they say that they really feel that they've had these symptoms their whole lives, and that they were that kid, right, that had these kinds of symptoms. So is it the case that they've always had a degree of this condition, or is that, in a sense, a coincidence of some kind, that they've had those experiences in the past and then later in life were diagnosed with IPAH?
So we don't know when IPH begins. We don't know if it begins at birth. We know it can, in some people that have mutations. We don't know if puberty aggravates it. We don't know if pregnancy aggravates it. All these things have been sort of linked one way or another, not linked strongly, but suggestive at least. We all see cases like that. And so we don't know how long it takes someone to block up 70% of their lungs. Hasn't been going on since they're born. Hasn't started at puberty. Was there a second stimulus? I have one family where the a woman, got sort of classic heritable PAH at the age of 28. Okay, and her father, who had been jogging, developed PAH at the age of 72. Severe PAH. So again, and they both have the mutation or a mutation, and so the age of presentation can be very variable. It's possible that the person has had it all along. It's possible that they've had some sort of vasoreactive phenotype all along. We don't know. Nobody knows.
Yeah, anything to add? I see Mitesh is answering some questions there in the chat. Thank you very much. All right. Okay, well, it's 12 o'clock, so we've come to the end of our time. Hi, Molly. Welcome. I always like to see our animal friends on our calls. I'm actually a little surprised that I got left alone for my session because I've usually got a cat with me. Anyway, thank you so much to each of you for your time today. Thank you to all of our participants for your questions and your discussion in the chat. We really appreciate you coming out and spending some time with us and asking your questions. And again, just to all of our panelists, we really appreciate all your expertise. We know you're very busy, so thank you so much to all of you. Have a good afternoon, everybody. And just two last final announcements. Again, if you'd like to rate your sessions, please go back into the program on the conference website, and you just go to the bottom of the session page and click on the feedback survey, and you can provide us your feedback on individual sessions right there on the website. And then finally, just another pitch for joining us this afternoon for our final social event of the week. We are having a community open mic. It's going to be a fun little show starring Ottawa's Jane Cernosky as our host. It's going to be a bilingual event, so we will have simultaneous interpretation so that all of our Francophone friends can join us as well. So we hope you'll come out and enjoy some stories and some songs and probably a little bit of dance and just generally have some fun with us for a little while. And then again, tomorrow is our closing day. We have a feature workshop in the morning with Dr. Weatherald and Dr. Melnichuk on patient-centered care and quality of life. I'm looking very forward to that one myself. I think we're going to learn a lot about the sort of the future direction that some of our treatment philosophy is taking. And then there's also going to be a special session on pediatrics research. And then very finally at 11:45 my time, we're going to start our closing plenary with Dr. Provencher and a panel discussion on new research for PH. All right, so thank you very much again, everybody, and we hope to see you again this afternoon and tomorrow morning. Bye. Thanks, Kelly.
Thank you very much.
Bye, everyone. Have a great day.
Thank you.
Thanks, Jamie. Thank you.